Okay. So I'm supposed to be discussing HRT, and I'm just going to talk about the bits that I feel were relevant for the exam, which included things like the contraindications, both the absolute contraindications, the relative contraindications, and then the indications for transdermal, and then talk about the way we do the prescriptions and who we give it to and who we don't give it to. And then we look at adverse effects as well. So just to simplify it for everybody, anytime you hear sequential HRT, is the same thing as cyclical HRT. Personally, I prefer to call it cyclical because it's easier to understand as cyclical. But just know that anytime you hear cyclical, is the same thing as sequential. So now, when you're doing the prescriptions or when you're trying to give somebody HRT, there are only three ways you can possibly give this HRT. So it's either as a monthly cyclical dose, in which case every month the person has the prescription is given as a monthly dose, or it's given as a 3-monthly cyclical dose, or it is given as a continuous combined. Those are the only three ways HRT can be given. Now, to differentiate between the monthly cyclical HRT and the 3-monthly cyclical HRT is all about when you give the progesterone. So it's called cyclical because you're not giving the progesterone and estrogen, particularly the progesterone, every single day. The estrogen is a constant K, is always given every day. Okay. But the progesterone is given for 14 days at the end of the cycle. So if it is a monthly cyclical, it means that you're going to be giving the progesterone at the end of the cycle for 14 days. So if, for example, somebody has a 28-day cycle, the last 14 days is when you give the progesterone. Now, if it's a 3-monthly cyclical, it just means that you give progesterone every day for 3 months, 13 weeks, and then at every 13th week, you then give the 14 days progesterone, and that's it. And then you start the estrogen all over again. So that's what it means when they say the monthly cyclical, the 3-monthly cyclical, and then the continuous combined is just that you're giving the estrogen and the progesterone together every single day. Do we get it?
Yes.
Thank you.
No, please.
Sorry, can you go over the 3-monthly one again?
So the 3-monthly one is still the same thing as you're giving estrogen every single day for 3 months, but we know that 3 months is 13 weeks, right? So you're going to give estrogen every day for 13 weeks. Then by the 13th week, you'll now give progesterone for 14 days. So every 13th week for 14 days, you give progesterone. That's just the 3-monthly cyclical. Do you get it?
Is the progesterone given alone, or is it in addition to the estrogen, or estrogen just stops at 13 weeks and then you give progesterone?
So the way it wasn't clear, the way they said it in NICE, they just said that you would give the progestogen for every 14 day, every 13 weeks. So I believe that you would at some point you will add it. I believe it's an addition because in the monthly it's an addition.
Okay.
You get, but they didn't state it like that in NICE. But if we're to borrow from what they do in the monthly, I think it's an addition that they do.
All right.
Does anybody have any other question?
Yeah, please. For the monthly, yeah.
Mm-hmm.
The progesterone, is it given at the 14 to 28 days, or is it after the 28 days they now take it for 14 days?
So it's on day 14.
On day 14 to the last month. Yeah.
To the last day, yes, that's how it is.
Thank you.
Yeah. Any other question?
Okay. Hello. Thank you very much for the presentation, but I'm a bit confused when you say addition. How do you mean addition?
So the person has been taking estrogen every single day from the beginning. You're just adding a progestogen. So the person has been taking estrogen with no form of progesterone. Do you understand?
Thank you, yeah.
Yeah. Okay, so if we understand this prescription, right, you then understand why it is given. So for perimenopausal women, the only way you can possibly give it is a cyclical method. because the perimenopausal women still have most of them still have their uterus, and they still tend to want a form of regularity in terms of their periods and things. Okay, so if you think about it that way, you realize that for the perimenopausal, you can only give them either a monthly cyclical or a 3-monthly cyclical. By the time the person is going into menopause, the menopausal women can have either the cyclical or the continuous combined. However, most people, and NICE would say, most people would prefer to give the continuous, because in the continuous, there are no bleeds. Think about it this way: somebody that has finished suffering with periods all the days of her life, then she has now gotten to menopause, you now want her to continue having bleeds every month. No. So that's why they do the continuous for them. But it's not that they cannot have the cyclical. It's just that that's what they prefer to give them. Do we get it?
Yes.
Okay. So if we understand the way the prescription is, now we can go into like the different kinds. Now, with HRT, there's patches and there's oral. That's the way it is. It comes as oral and it comes as patches. Now, the patches, no, not patches, sorry, oral and transdermal. So the transdermal is now the one that is broken down into 3 different types. That transdermal can either be patches, or it can be gel, or it can be spray. Now, when you think about the patches, right, the patches, so the patches and the oral can also be combined, or it can be only progesterone in them, or it can be only estrogen. Do you get it? So for the patches that are only progesterone, there are only 2 types of progesterone that you will see in the patches. So in case you see a question that is asking about progesterone and the patches, just know that it can only either be norethistérone in that patch or levonorgestrel in the patch. All the other types of progesterone are in the oral medication. They are not in the patches. Now, in terms of the indications for giving somebody a transdermal, so this transdermal now we know is either patch, gel, or spray, but commonly what we use is the patches. Think about anything that would stop you from giving somebody an oral medication. So either the person has a GI disorder that is affecting absorption, so things like lactose sensitivity, maybe the person has a gallbladder disease, those kind of people, you want to give them transdermal patches. Then also think about people who have an increased risk of VTE. So you know that the more systemic things you get, the more likely you are to have VTE. So anybody that has that, anybody who has any contraindication to the oral medication. So let's say people who have migraines. People with migraines, you don't want to give, you want to give them the transdermal patch rather than the oral one. If the person has had probably a reaction or something funny to the oral medication, those are all the indications that you want to use. And obviously, with the VTE one, you're also thinking about cardiovascular risk. So people who have uncontrolled hypertension, people who have raised cholesterol levels, hypertriglyceridemia, obese people, the patches are preferred for such people. So those are the indications for the transdermal patch. So if you just think about, if you see the question, think about anything that you feel is a contraindication to somebody having an oral version of the tablet of the medication, they'll have the transdermal patches. Then for the generally now, in terms of HRT, there are absolute contraindications and there are relative contraindications. Now, the absolute contraindications are very similar to your contraindications for COCP. Okay, so things like people who currently have a current history or a past history or even a suspected history of breast cancer is a no for them, no HRT. If they are known to have a suspected or they are known to have an estrogen-dependent cancer, and we know that there are other cancers that are, estrogen-dependent, you don't give it to them. undiagnosed vaginal bleeding, so you're not sure if it's endometrial cancer or not, you don't give it to them. Untreated endometrial hyperplasia, you don't give it to them. People who have VTE and they are not on an anticoagulant. So if they have VTE but are on an anticoagulant, you can still give them. You can start to consider a patch for them, but definitely not oral. Then people who have an active or recent arterial, basically VTE things, all of those kind of, but people who have liver disease, you don't want to give it to them. People who are pregnant, people who have a thrombophilic disorder, those are absolute contraindications. Then the relative ones are things like DM, porphyria cutanea tarda, and then people who have a predisposition to VTE, you may not want to give them those. People who have migraine-like headaches, you don't want to give them that. People who have like a family history of breast cancer, you want to consider that. So that's then the adverse effects. Just remember that the adverse effects for estrogen and progesterone are very similar. They all cause fluid retention, but obviously these things are kind of more in progesterone than estrogen. However, they all cause fluid retention, they all cause breast tenderness and enlargement, they all cause headaches, they all cause nausea. The ones that are really, really specific to the progesterones are all these things like mood disorders, depression, premenstrual syndrome, all these things that have to do with psychiatric kind of behavior. Is progesterone that has all of it, but both of them have the fluid retention, the bloating, nausea, headaches, all that kind of stuff. And that's the HRT.
So what happens to people who don't have a uterus and then you're giving on the estrogen? Is it just continuous? Like, well, definitely it's continuous, right? There's
Yeah, so it's
no
continuous that you give them, yeah. It's because they're, especially if they are postmenopausal. So at that point, what will guide you in a way is their age. Are they perimenopausal? Are they postmenopausal? For those ones. Does anybody have any other question?
So the continuous in
Yeah.
that sense is just estrogen with no progesterone.
No. Continuous combined, right? Is estrogen and progesterone every day.
That's what people get with no womb or
So
post-menopausal.
people who don't have a uterus, they say that you can give them just estrogen, just a continuous estrogen. Do you understand? So yeah, so you can call that just continuous, yes.
Okay, because I was thinking continuous was just estrogen without progesterone.
So that's the thing. So this HRT can be given as combined or as single, and that depending on how you want to play around with it. So for people who don't have a uterus, yes, you can just give them the estrogen. You don't bother about the progesterone bit because they don't have anything to get cancer. But those of them who need the combined therapy, so those of them who have a uterus now that need the combined therapy, you can now do the combination anyhow. It doesn't have to be that the patch has or the tablets is a, so you can give somebody now with, you can leave somebody with Mirena and then just be giving the person estrogen tablets. Did you get it? Or you can do a progesterone patch and taking estrogen tablets. It's just, they now just mix it anyhow, any one that fits, because the thing about it is that they dosing, because you start with the smallest dose when you're starting HRT and you build it. So sometimes some people don't get the relief that they need on the manufacturer prescribed dosing, and you cannot cut it. So at the end of the day, they will end up mixing it. So some people will be on a mixture of a patch and an oral medication, or the Mirena and a patch or something. There's always one combination, one mixture or something of the sort.
So for people that have no uterus, you can give them only estrogen continuous.
Yeah.
Women that are post-menopausal, that are no longer bleeding, you can give them combined continuous.
Exactly.
Okay.
Yeah.
Please, I don't know if you could help me out with this. So at the end of work today, I just spied and I just noticed that my first patient for tomorrow will be a 40-year-old lady who is actually coming in because she wanted HRT.
Okay.
I'm just thinking for a 40 years old lady, obviously, I'm not even sure she's premenopausal, but she's claiming to have menopausal symptom. Will I actually be thinking of giving her HRT, or will I have to investigate her? I know, of course, if we're thinking of menopausal symptoms, we don't need to investigate and all that. And I'm not sure. I think for definition of menopause is 45 and above. I may be wrong. But I'm just thinking 40, will it be appropriate even if she's got those symptoms for me to start her without investigating her?
So I think the definition of premature ovarian failure is less than 40. I don't know if I'm wrong, if it's less than 40 or less than 35. But if she's 40 and there are a lot of questions that need to be answered. First of all, when was last time she had a period? What kind of symptoms is she having? Is she having, all the hot flushes for all the menopausal symptoms, basically? If she fits the bill for this, and then if she fits the bill as perimenopause, you have to manage as perimenopause and give her HRT. If she doesn't fit the bill, she fits the bill as postmenopausal until she has actually become postmenopausal, then it should be managed as postmenopausal. And then you also have to consider, does she have a uterus? Does she not have a uterus? You also need to make sure that check her blood pressure and all those kind of things to make sure that she actually fits. And then you also need to check things like cervical screening. When was the last time she had cervical screening? Because you want to make sure that there's no cancer brewing anywhere before you start looking at HRT for her. But I think you need to have that conversation with the lady first, and see where she sits. Because I think 40 is I don't think 40 is premature ovarian failure. I think there are people who actually might go into menopause at 40. Correct me if I'm wrong. I'm not really sure now.
I was listening to one podcast and they said something about this as well, because some people come in with these symptoms at an early age. And they said although blood investigations are not done to diagnose menopause, for someone coming in younger with these symptoms, especially when they've not seen their period for a very long time, it's still good to have some blood investigations first before thinking of starting any medication.
Okay.
So you have to consider that when you are seeing the patient tomorrow as well.
Yeah. Plus, I think also you need to also consider, because some of these patients come in and they've been on like a long-term contraception for a very long time. So they don't even remember when their period was and when their period was not. So her having, not seen her period may not actually be a true reflection of her body now being in menopause, but it might just be that she has been on a long-term contraceptive for such a long time that it has not yet rebooted. So yeah,
my worry was mainly her age anyway. That's my major concern. That 40.
Yeah, but look, the definition says before the age of 40. So
okay.
Yeah.
Thank you. Okay, so I saw a patient like that during my rotation in this surgery. So she was 39. She was already on HRT because she was having vasomotor symptoms and it was really affecting the quality of her life. So there's this clinic in Birmingham. She kind of champions HRT a lot. I've forgotten her name now. So she actually had to go to that clinic to get her HRT started. But I think because of her age, normally when it is less than 40, we consider premature ovarian failure. So you need to do all the necessary investigations to rule that out, as well as what Ada has said, taking like a very detailed history and all that. But they champion HRT a lot these days, and they encourage people to have them even when they're not yet up to the age that we are used to, like 45 and all that, because we've had women less than this age who take HRT to control their symptoms. So I think probably something you'd want to look into. And what I would also suggest is probably after requesting for all the investigations, you can use NICE guidelines as a guide. You can also write to the Ops and Gynae department for advice and guidance, stating the investigations you have requested for, and if they will be willing to see her in their clinic, or which other advice they would recommend, or treatment or investigations they would like for you to do for her. I don't know if that helps.
Thanks, Diamond. Thanks.
And the thing with, and one more thing, even if the woman's having premature ovarian failure, they still treat them with HRTs as well. So you can't go wrong with HRT treatment anyway.
Yeah, but it's not advisable for me to actually start her until she has those investigations done. Is that the bottom line?
It depends on, like what she said, depends on her symptoms first. But I would still be safe
Yeah.
to do the investigation since she's
Presuming she has all the symptoms.
If she has all the symptoms disturbing her quality of life, I think do the investigations and consider starting on the HRT, because the thing is, HRT is going to help the quality of life, and you can give HRT to someone that's perimenopausal as well. So I think it's a balance. You have to find the balance to do the investigation, see the quality, how her symptoms are affecting her. If she could wait for the investigations, then fine. If she can't wait, then start the HRT. There's no harm in starting HRT as long as there's no contraindication.
Yeah, makes sense. All right, thank you.
Okay. In addition as well.
I've just had a look on the CKS, and it says while FSH should not be used to diagnose menopause in women with atypical symptoms, it should be considered. And in women aged 40 to 45, even though 40 to 45 is early menopause, she could well be menopausal. You should consider doing FSH. So I think for this lady, as they've all said, do your history, but do the FSH and see if it's elevated and see if she qualifies or if there's something else going on. So you can actually diagnose her menopause using bloods because it's so early.
Yeah.
That makes sense. Yeah. I'll just put a screenshot on the group afterwards.
Yeah, thanks.
No problem.
And don't forget pregnancy test as well, because she's
Yeah.
That's true.
Right.
And in addition, please also tell her about the other options, because they might also always be fixated on HRT, and based on her symptoms, other options might also be
lifestyle and all that. Okay.
Yeah, and even all those SSRI sort of things, so that she's fully informed and then makes an informed decision, basically.
Yeah, makes sense.
And if you're starting the HRT, also let her know that she can actually get pregnant. That if she's
so she
not
needs
fully
contraception.
menopausal,
Okay.
she needs contraception as well.
Yeah,
Perfect.
makes sense.
Perfect. Thank you, everybody. HRT is always an interesting discussion, and every GP should be very good in managing menopause. Thanks. Very interesting discussion. These are the reasons why we sometimes put up discussions and presentations, because it does sometimes clear the air about certain things.